Good afternoon, everyone, and thank you for joining us. My name is Ashley. I am with the AIUM, and I will be your host today. As part of the continuing education for healthcare professionals, I am pleased to host this webinar on artificial intelligence and the ways it can help in private practice, presented by Dr. Ron Hidalgo. This program is a non-CME educational activity in a collaboration with Samsung. Today's webinar will cover the understanding concepts of basic artificial intelligence, how to find artificial intelligence resources, and getting started, and learning where artificial intelligence is being used. If you have questions for the presenter during this webinar, you may type them into the Q&A box at the bottom of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering questions until they have completed their presentation, at which time he will answer as many questions as possible. And now I am pleased to present Dr. Ron Hidalgo.
Hello. My name is Ron Hidalgo. I'm a radiologist from Springfield, Illinois. I work with clinical radiologists. And I wanted to talk to you a little bit today about artificial intelligence and how to understand what that is, how to get started in artificial intelligence, and ways that I think you can apply artificial intelligence in your practices. So again, what we're going to talk about today, just basic terminology, wordings to understand what's the difference between all this lingo out there. Where you can find resources to help you get started in artificial intelligence and ways for you to actually apply this, to do it yourself or find ways to incorporate it into your programs. And just see examples of different applications of artificial intelligence in the world right now. So to get started though, we have to kind of talk about the background of imaging. Background in radiology has really undergone 3 phases of imaging over time. The initiating phase was termed Imaging 1.0, and this really was a period of discovery of imaging and learning how it worked and what to do with it, really from the 20s until 1990s. And this era was thought to end when CT and MRI came out and we started to have more advanced imaging technology. That led us into Generation 2. In Imaging 2.0, we really started to see the advance of picture archiving and communication systems, what we call PACS. These began to surge in the 90s, and that led to a dramatic surge in our efficiency and our productivity. Radiologists flourished as revenue centers using a fee-for-service payment system. But the problem was that it created an isolation from our patients, from our healthcare teams, and from our referring providers. So despite all the advantages, there were disadvantages to this new technology. And that's led us into what the ACR is calling Imaging 3.0. The goal of Imaging 3.0 is to take us back to our roots, foster collaboration between the radiologists and the patients, get us back talking with our referring physicians, and anyone else that's interested in appropriate evidence-based imaging and management. So now let's talk about artificial intelligence and where it fits into that. Artificial intelligence is not a new concept that we've thought of in the last 4 or 5 years. It was first initially proposed in 1956, and its intention was to understand, simulate, and improve upon human qualities such as reasoning, learning, solving problems, understanding verbal and written language, processing visual information, and playing games. So a huge base that people thought AI could help us with. And a lot of that does include imaging, does not include imaging. But it kind of lost track. People kind of forgot about it. The technology wasn't there to really make it work. But in recent times, we've seen a big resurgence in interest in AI. And why is this? Well, you could thank video games for that. Xbox and PlayStation have been a big factor in this. We've seen with those consoles the need to compute images very efficiently. And this spurred the development of these highly parallelized graphics processing units. So these advanced GPUs started to allow us to be able to process images faster, see more complex, more sophisticated images, and create neural networks, neural models that can help analyze these images. If you look at neural networks 10 years ago, they were only 3 or 4 layers deep. If you look at a neural network today on some of these systems, hundreds of layers deep, processing tons of info at the exact same time. And that led to, probably a few years ago, you remember all the excitement was about machine learning has learned to recognize patterns in images. And that was great. Everybody was really excited. They created an artificial intelligence system that could pick out a picture of a cat on the internet. So obviously the next step is that radiologists are no longer needed because all we do is look at pictures. So if an AI can do it, anyone can do it. But the reality is AI and radiology cannot and will not exist in isolation. We have to use AI to advance knowledge and improve our healthcare. So while it can recognize things, there has to be some radiologist involved trying to help. And this process has to be both what we call human and humane. Not only does it have to help us care for patients more effectively, but it has to help us do it in a more humane way. So we can't let the machine take over and let this be an automated process. There has to be that people intervention and people interaction through all of this. So ultimately, the goal of AI should not be to replace, but to augment and help us provide medical care to patients and improve the lives of the patients that we serve. So if you really think about it, though, AI is not the first time that people said, "Oh, radiologists are doomed; they'll never make it." The first time we actually started hearing about this was when MRI came out. People were so convinced that MRI would be the best imaging technology of all because these high contrast images would make the images, the abnormalities appear so obvious that a family practice doctor or someone who's not that trained in imaging could easily open the study, find the imaging or find the problem on the picture and tell the patient how to solve the problem. But the reality is that's not how it works, and MRI is one of the more complex studies that you can read. So you still have to have a radiologist there to help us guide patient care. So that leads you to the concept of how can we let AI do this? We watch movies and movies can scare us. And it seems to be that there would be the logical outcome of, let's call it the Terminator outcome. Computers eventually outstrip human intelligence and supersede humans altogether because we evolve so slowly, but computers should be able to evolve very quickly. You've seen this in Terminator and iRobot, lots of movies. Computers take over and eliminate us. Well, that's a pretty dim picture of artificial intelligence, and nothing I've seen makes me think that that's even the direction we should go. Then there's the other concept of human-computer symbiosis, where we say that technology is meant to augment human insight and decision-making performance to help us achieve things that were previously unachievable. So again, AI is designed to help us, not replace us. And that comes to this. I love this terminology, and I think we've been talking about AI and radiology, but the term I like is this augmented radiology term that I've seen out there. And what this means is expediting identification of incidental findings, searching for relevant comparisons, eliminating unnecessary workups, help us improve evidence-based management, and facilitate real-time communication. So none of this says have the computer find the finding and don't worry about what the radiologist thinks. This says have the computer help the radiologist find the things that are most important and then help us find the best way to manage them. Now, that may sound simple to some level, but it's more challenging on every level. As most of you know, you come from different institutions, you have many different vendors, and none of them work the same, none of them communicate very well. There's so much proprietary technology out there that it's difficult to create a uniform language to talk in. So we have to find a way to break down this information technology silo to actually make this become more efficient and work. And one of the things that we have to recognize is that we as radiologists must be actively engaged in development. I feel like this is one of those areas where maybe we lacked, particularly when it came to PACS systems. Many of you use PACS every day, and you recognize that these features are there. They seem great. They seem like they should work, but they often don't work how you think they should work. And a lot of that's because PACS systems were developed by big corporations. Radiologists were not always actively engaged in the development of all these different PACS systems. So if we can stay actively involved and engaged in the development of these AI technologies, we'll be able to create things that are actually useful for us and work the way we want them to work. And the other thing to recognize is that AI may be able to detect horses, but zebras are much harder to find. So connecting all the dots on the different findings on the images, that still lies in the bed of radiologists. AI can find simple things, but it may not be able to find everything. So what are different ways that we can get started in AI? There's a ton of different available resources out on the internet. One of the best ones that you can refer to is the RSNA, the Radiologic Society of North America. They have tons of information available for you. One of the biggest ones is to go to the annual meeting. They have tons of AI courses, refresher courses, scientific sessions dedicated just to this concept. You'll find exhibits and posters in their learning center. You'll find tons of data sets that you can access from to help you perform your own AI research and development. They have a deep learning classroom to help you learn how to do algorithm creations. They work with the National Imaging Informatics curriculum and course, and that can help you learn how to get started. They have annual machine learning challenges. They've had a bone age challenge. Last year was pneumonia detection challenge. This year is pulmonary embolism detection challenge. You can subscribe to their artificial intelligence journal. It's a great place to see all the different articles out there and what people are working on and what the literature is saying. They've also got an entire vocabulary area to help you learn what these difficult terms mean. They've actually taken AI and subsetted it into 6 different categories: clinical implementation, education, research, data collection, ethics, and business. And within these different areas, they've highlighted some of the more important ones for us, education and data collection being the ones that they feel like we should be focusing the most on. But AI can apply to all of these different areas. And as you can see on the right, there's just showing you a different table of all the different things that the RSNA is working on within these different themes in AI. So let's talk a little bit about how AI has happened in the past. Like I said, it was in the 50s when we first started talking about this. Recently is when we really seen the spike, but it was really in the 90s that we first started to see the concept of some computer-aided detection. Back in the 90s, we were seeing a lot of variable quality in mammography interpretation. So the breast imaging reporting and data system was created, and also known as BI-RADS, which became one of the most influential advances in the history of radiology communication, trying to standardize a lexicon and standardize a management path for us. It was so successful that the legislation actually decided to provide reimbursement for radiologists who would use artificial intelligence to help detect breast cancer on mammograms using computer-aided detection systems. So, like I said, 50s and 60s was that first era of AI where people had the ideas, but we didn't have the technology. But in the 80s and 90s, we started to see these computer-aided detections, particularly used in mammography. It wasn't everything that people hoped it would be. And in fact, it may have been the opposite. It led to an extreme disillusionment in the use of computer-aided detection, which ultimately led to an AI winter. These systems would detect things that were nothing, but it was slightly different from the baseline pictures it was trained with, so it thought there was something wrong. So in all reality, it actually started to lose its benefit or have no benefit. It led to a high false positive findings and to alert fatigue. So radiologist accuracy actually was found to be decreased in some of the literature. It led to higher recall rates and higher biopsy rates. And it actually led to an increased time needed to interpret a study rather than a decrease. So despite the fact that we were able to get reimbursed, there were actually many downsides to the use of computer-aided detection. And so that leads us to the third area of AI, which is deep learning algorithms. So before we talk about deep learning, let's kind of understand the difference between CAD and deep learning. A CAD is a computer program designed to perform a specific task. The CAD is designed to help you analyze mammography, a mammographic picture. You could not take that same algorithm and apply it to a chest x-ray or anything else. It wouldn't know what to do. When you program using deep learning, it's task agnostic. You can actually program any of these algorithms to do anything. The other thing is we know it works. If you look at applications outside of medicine, we're starting to see cars with automatic driving technology. We have your phone able to categorize your photos for you. Your phone can understand your speech. It can actually help you start to respond to your email. So we're seeing these deep learning algorithms learning our patterns and being applied outside of medicine. So the next logical step is to how do we apply it in medicine? So what we see is people attempted this, and there was actually an image analysis competition. They took traditional CAD models and compared it to these deep learning algorithms. And they found that the traditional CAD methods led to 5 times as many errors as a practiced human when asked to identify everyday objects in photographs. So again, the CAD was able to perform its specific task, but not always very well. Now, when they took this same concept and applied it to a deep learning algorithm, they actually found that it surpassed human performance and made about half as many errors as humans over the course of the challenge. Now, deep learning is a great term, but I've already said the term artificial intelligence. Then there's the other term machine learning, and then there's the term deep learning. So they all kind of fall into this bubble. The overlying concept is artificial intelligence, which is enabling machines to talk like humans. Once you get into that, you fall into these subsets. The first subset is machine learning, where we're teaching machines to get better at a task without explicitly programming it for that task. Then you get deeper into that, you get to deep learning, where we take multiple layers of networks and use those in deep learning. So it becomes more of a self-training module. So AI is any technique that enables computers to mimic human intelligence. Machine learning is a subspecialized field of AI that enables machines to improve performance of tasks with experience. The algorithms parse data, learn from the data, and then make informed decisions based on what it learned. Deep learning is more subspecialized within that machine learning, and it uses these deep neural networks, and they get exposed to large sets of data. And then these large neural networks form that can learn and make intelligent decisions on its own. So once you start to get more into independent learning, that's when you're talking about deep learning. Machine learning is that basic level where it takes information, processes, and it gives you an output. It produces the same thing every time based on what it was initially trained on. Deep learning can take that information, find where it's made mistakes, and then learn from that. So here's just a great little diagram I thought, kind of displaying that. You have an MR image of a brain that gets put into your neural network, of your machine learning neural network. It gets processed based on whatever features it learned, and it gives you an output that says it's an oligodendroglioma or an astrocytoma. Simple enough, that's all it is. Now you're going to take that same concept and apply it in deep learning. You're going to take that image, apply it into your deep learning algorithm, and you're going to see it go through multiple nodes, hidden layers, analyzing different features of the image, figuring out which feature is good, which feature is bad. And after you get through all of that, that's when you get to your output. So a little bit more about how that works. The pixels from whatever image are fed into the input node, whatever your first layer of that node is going to be. Using that, it begins a prediction phase. In that prediction phase, the data is propagated using sets of weights. These weighted features determine different things. Like if something's too bright, too dark, it'll start to parse things out based on those data sets. And eventually it'll give you a numeric classification that's compared to the ground truth that tells you how good it is versus what the human said. Now, once it determines whether it was accurate or not, it can do something called backpropagation. It'll send that data back through the network based on any adjustments made by the end user, and it'll adjust those weights. So maybe something is T2 intermediate versus T2 bright. And then it'll put it back through, repeating the process of prediction using these new weighted data sets. So eventually these weights progressively refine, and that's how you ultimately get to your correct output. So here's just kind of an example showing you that. Same idea, the input layer, the old model of machine learning where you just go into a single layer and have an output versus that deep learning neural network where you can see it start to identify all these different features of the face. Now it's going to take all that and backpropagate, predict, backpropagate, and predict until it eventually gets you to your output layer confirming that this is George Washington. So how can we get started? There's a lot of different ways for you to get started in artificial intelligence. One is to do it yourself. If you really have an interest in doing artificial intelligence, doing it yourself is a great way to do it. Or partnering up with a local university computer science program and learning how to do it with them. And one way to do that is through cloud computing resources. Google has something called the Colab network, and it allows you access to their cloud service where it has learning resources. It allows you to create and share code, text, data, and tools. You create these programs in a text editor and then run it with an interpreter or compiler. And then using that, you're able to start to use their network to create your own deep learning algorithms. Another way to do it is start with your residents if you have residents at your program. One of the best examples that I've seen of this is at Mass General. They have something called the Mesh Incubator Program. And to me, this is one of the greatest concepts I've heard in a while. They actually create this 1-week course that any resident, any specialty, I believe, can sign up for. And in that course, they're going to learn all these advanced imaging techniques and technologies. They'll learn 3D printing and segmentation. They'll learn artificial intelligence. They'll learn programming. They'll learn about intellectual property and grant writing, all the things that they need to help them get started in the world, creating their own technology and getting started in all of this. I think this is a great concept. And I think as we move along and people start to get more experience, we'll start to see more of these come about. In fact, my own program, we have something that we've called the Imagineering Lab. We offer it to residents and med students, and right now it has 3D printing. We have a MakerBot, and we have Materialize, and we teach our residents how to do 3D segmentation and about all the materials that are used in 3D printing. And soon we're hoping to implement some augmented reality into that, and then eventually expand it into artificial intelligence. So far, we've had a few residents go through it, and at least one med student, and they've all enjoyed it, and they've done a great job. We got a little derailed by COVID, but we're finally getting started again, and it's been a very successful program. So if you don't have the ability to do that, or you're no longer in a residency program, or don't have a residency program, but have an interest in getting started, you can go to the National Imaging and Informatics Curriculum and Course. And this is a week-long online course open to anybody, residents, students, an entire institution, and it's intended to introduce the fundamentals of imaging informatics. And what you'll get in that course is recorded lectures, live lectures to be delivered online, live online small group discussions, problem-solving sessions, and you'll get tested at the beginning and tested at the end to see what you've learned. This is a great way for anybody who's not involved in an educational side of things to get started on this and learn how to do it on their own. Well, let's say you don't really want to do anything on your own and you just want to get artificial intelligence in your program. You can. You can do multiple. There's two real ways to do this. One, you could find specific applications that you're interested in artificial intelligence, whether it's pulmonary nodule detection or whatever it is, and you can buy specific apps dedicated to do that. That can be costly, and that can be difficult for an IT department to manage, because you can end up with multiple different applications, and finding ways to integrate them can be complicated. So what some of these bigger companies have found is that the ideal way to do this is through what are called AI marketplaces. Three of the big ones that I know of are Singovia, Arteris, and Eureka Clinical AI. You may have heard this as Envoy AI, but this is Terra Recon's marketplace. And a lot of these smaller programs that you see out there that you could purchase individually actually buy into this marketplace. And so when you purchase the platform, whether it's one of these three or another one that exists, you actually gain access to all the programs that are a part of that program. So you actually gain access to a lot of different AI applications. This to me is probably the best way to get started, particularly if you're in a more, you need many different applications. This will help you kind of coordinate it and let you use the ones you want to use and not use the ones you don't want to use, all for one price instead of multiple prices. So what are some of the things that we can do with AI? So ideally, we can improve efficiency and accuracy of image interpretation. We can help find important findings with greater precision. We can prioritize and triage cases that need interpretation. We can find imaging patterns that may help us find the most effective diagnosis and treatment. You can go deeper to that before you even get to the interpretation level, and you can look at the acquisition phase. You can improve image quality, and you can improve the acquisition speed to make your images better. So we'll see detection algorithms used to solve these needle in a haystack problems. We'll see registration and segmentation tools to help you analyze and track lesions, organ volumes. But ultimately, they all allow the radiologist to exercise their judgment and interpret the images in partnership with these algorithms. Again, going back to that concept of augmented radiology. So I'm just going to kind of run you through some of the different examples that I've seen or that I use in my practice or that I've had a little experience with, or just things that I've been able to find. So a couple of these slides come from a presentation. Some of you may have heard I gave at RSNA this last year. So the first one is talking about ultrasound. So the first one is S-Detect for breast. This is a great technology built into one of the Samsung machines. This is actually the same machine we have at my institution. And what we do is we find a lesion in the breast, and using this technology, we're able to outline the lesion with a simple box. And then within that box, the machine will segment the lesion and output some data about the lesion. As of now, we input a lot of this information, but ultimately the idea is for the machine to automatically characterize the lesion and then output the BI-RADS score for us. So from the machine, we come back, we can put a standardized structured report out from the machine, increasing our interpretation time, or decreasing our interpretation time, I should say. So here's just another example showing you that same thing. Here you can see a lesion, it outlines the lesion for us, and then tries to auto-characterize these things. And the same concept can be applied in thyroid. We have S-Detect for thyroid too. Currently we use it just for orientation, getting measurements, but again, you can manually insert this information so that it can output through an HL7 interface into your dictation systems, or eventually, as we get FDA approval, you'll be able to have the machine auto-characterize the lesion for you. So here's just another example showing you the potential capability for S-Detect in thyroid. Another great technology is this Easy HRI, and this is one I've been using a little bit here for a while now. And through a deep learning algorithm, the machine actually takes an image. It's typically a sagittal image, including the liver and the kidney. It analyzes the picture, segments out the liver, segments out the kidney, and then puts ROIs within the cortex of the kidney and within the liver parenchyma, and it gives you attenuation values in those areas, creating the hepatorenal index. So the idea of this is to help you track fatty liver disease, helping you try to identify patients' treatment, if it's working, if they're getting worse. So here's just kind of an example showing you how easy it is. You just push the button and boom, it puts those two ROIs there, gives you the value, gives you the ratio, and gives you the mean in that area. So here's another example of that. This one I've had a little experience seeing it in demos. I haven't gotten to use it myself, but I think it's a great idea. When we do prostate biopsies, we all know that the prostate biopsies tend to be random biopsies, but we can actually do fusion biopsies. And one of the ways that we do that is we stick the rectal probe in. We go through some complex fusion methods, and eventually you get this pretty fusion picture, and you can target a specific lesion. That works great, but every time you move, you have to realign the pictures, and it can be very timely. So what the machine can do is something called S-Fusion, and it allows auto-calibration in real time of the picture. So when you put the rectal probe in and the images are in the machine, it'll automatically do all that calibration. So as you move the probe, you see it move the prostate on the MRI in real time, allowing this to be a much more efficient process. The other thing that we know is that when you put a rectal probe in, it deforms the prostate. So the picture that we see on the MRI doesn't always match the picture that we see on the ultrasound, because there's been a change in shape of the prostate. The machine has something called deformation correction. It's actually able to, through AI, reform the prostate on the MRI to match the image that we're seeing on the ultrasound, so that you know when you target that lesion on the MRI, it's going to correspond to what you see on the ultrasound. So here's just another example showing that auto calibration and that deformation correction. It'll provide you some 3D modeling of the prostate itself. And fusion is not limited to prostate. We can actually use fusion in liver. And the platform is actually really simple. It just involves a little device that you put over the patient. And as soon as you load the CT or the MRI into the system, it'll actually auto-calibrate your CT to the image, and it'll give you perfectly correlated images. And as you move your ultrasound probe around, it'll correlate it to where you are on the on the MRI or CT. So you're able to, in real time, try to find lesions that maybe you would have had difficulty finding before, or identify parts of the liver to know where you're at. So here we can see another example of that S-Fusion, kind of showing you there's a little lesion near the diaphragm. We can see it on the CT. and we could see when it fused, and we could see that that is in fact the spot that we're correlating to. So this can help us find some of these harder to detect lesions that are small or in awkward places using this fusion technology. Another great interesting one is S3D arterial analysis. Using a special 3D probe, you can put the probe over the patient and it'll analyze a volume of the vessel for you. And over that volume, it'll give you the attempt to show you the diameter of the vessel, the thickness of the intima, the thickness of any plaque, any areas of narrowing, and give you the degree of stenosis. It's a very interesting technology. I like it. I've used it a few times. It takes some practice though to get used to doing it. Shadow HDR is another technology that we've been using at our institution. Sometimes you get prominent shadowing on the periphery of your imaging field, or you'll get shadowing from some other structure. Using Shadow HDR, it'll actually try to eliminate some of that shadowing. So it'll do some post-processing AI to let you see those areas just a little bit better. But technology AI is not limited to ultrasound. We can actually see it in CT. One of the examples here is just using mobile CT for hemorrhage and ischemia detection. And through a pairing with rapid and mobile CT, we can see an efficient way to image patients in the ambulance prior to coming to the hospital. And through rapid, we can get detection of intracranial hemorrhage, ischemia, areas of perfusion anomaly. So when the patient gets to the hospital, we're able to be ready to treat them for whatever it is they need treated, versus having to do all this once they get to the hospital. So I think this is a really interesting concept, and I think may help get you within that 90-minute window. We eliminate that lag phase once you get to the hospital. The really nice thing about this technology is it works on phones, so your neurointerventionalist can see this anywhere they are, and when they're on call, and be aware of what's going on and come in with a plan. Other things we see is there's technology out there trying to classify vessels automatically. You get a CT, you run it through this algorithm, and it'll show you what's an artery, what's a vein. And sometimes that can be a little bit confusing on these angiographic images. Aneurysm classification algorithms are there, trying to help you determine what type of aneurysm you're dealing with. There are programs out there designed to detect intracranial hemorrhage. This is an example of one of those. Pulmonary nodule detection. One of the applications in Arteris is lung nodule detection. It'll give you the nodule, it'll give you your measurements, and help you characterize and find these nodules. So this is a great one. I actually don't use Arteris's. I use the one through Singovia. They have a lung CAD application. And any cancer follow-ups or initial cancer workups or pulmonary nodule follow-ups or lung cancer screenings, I like to run through the Singovia lung CAD. It just gives me an extra layer of confidence. Does it catch everything? No. Does it catch things that are calcified all the time? Yes. But you're able to, again, because it's augmenting, you're able to say yes or no to what it is telling you, and you don't have to just accept everything that it says. Coronary arteries can be an interesting area to analyze. One of the ways that people are doing it now is through heart flow. You're able to pull out these arteries and do non-invasive CT-FFR. I find this to be a great technology. This is one of the ones we're working on getting started and implementing in my hospital. We've seen technology out there that'll take sagittal images of the spine, segment them, identify the vertebral body layers, and help you identify fractures. We've seen technology to help you find the spleen volume. A lot of us right now, we do either a craniocaudal measurement or 3 measurements, whatever it is that we're going, but we don't always calculate the volume, or this isn't a great shape for calculating volume. But using some of these AIs, we're able to get the exact volume of the spleen, help you follow these patients. Same can be said for kidney. There's auto segmentation for kidney. So you can follow some of these patients with polycystic kidney disease and see how their treatment is going. X-ray is another place that we're looking at this. Some of this is showing you some of that deep learning networks and all the neural nodes, but this particular technology, this is supposed to simulate grids. A lot of times we do portable X-rays, we're not able to do grids, so we get lower technology. But using AI, we're able to improve the look of these images using simulated grids. Basically, they do scatter field estimations and then compensate for that. So we're able to get better pictures using SimGrid. Here's just an example showing you a difference of without a grid and then using SimGrid. You can just see it's a higher quality image. Again, here's another example. Here's a portable abdomen on the left. You can see it without a grid. On the right, you can see it with sim grids. And there are studies out there published showing that radiologists have shown a preference for images with sim grid versus no sim grid. There are bone suppression technologies out there, just as simple as clicking a button. It'll output you an image. It'll detect all the bones, the rib cages. It'll get rid of it for you, and it'll show you what the image looks like without those bones, helping you see the lung parenchyma and identify any abnormalities in that area. Here's just another example showing you a little nodule hidden right behind a rib. When you suppress the bones, it becomes much more clear. So again, same concept, showing you kind of a hard to see pneumonia. When you get rid of the bones, you can see there's just this streaky opacity down in that right lung base. So there are other technologies out there in MSK applications helping you detect fractures. People have done it with bone age, and they've shown good success when comparing radiologists versus some of these automated algorithms. There are pneumonia detection algorithms, things detecting thoraces, nodules, masses, effusions, enlarged hearts, you name it. There are all these different algorithms out there. Hip fractures, there's technology to help us identify fractures in the hip, whether it's periprosthetic or in a native hip. There's even a technology out there to help us detect and try to classify or grade the degree of osteoarthritis in a knee x-ray or whatever particular bone you're looking at. Again, you know, lung nodule detection is not limited to CT. We've seen technology out there trying to automate it in plain film. So using this particular example on the Samsung X-ray machine, running through their deep neural network, you're able to see this automated lung nodule detection. So here's just another example showing you a little nodule that it detected in that right lung base. We've seen a lot of technology out there coming in recent times trying to help us analyze and detect COVID. So we're able to input CTs of the chest, segment the lungs, segment out the abnormalities, whether it's ground glass areas or consolidative areas, and then quantify the severity of that and give some graded severity scale. So here's just an example of showing you this technology, showing you different CTs of patients with COVID, showing you the output of the machine versus the ground truth. And in a lot of these cases, you can see the output of the machine is very close to what the ground truth is that a human detected. So there are algorithms out there that are very good at detecting COVID. Interstitial lung disease is another great example. Through this Atlas network, we're able to see this patient has bad interstitial lung disease. And we could see the ground truth through 3 different radiologists who segmented these themselves. You can see they're slightly different, but pretty close. And then you can see that compared to what the AI did. So there's a lot of technology out there that can help us do these things. Even catheters, this can be very challenging. You know, figuring out what's a catheter, what's overlying hardware. But using some of these AI algorithms, we're able to see and identify what these tubes are and help us make sure on these portable x-rays we're getting the information that the ordering provider wants. MRI, we have tons of applications in MRI. Let's talk about a couple, whether it's brain tumor analysis. To one of my areas of interest is cardiac MRI. Designing the planes can be quite challenging and quite time consuming for the tech and can sometimes require radiologist oversight. But using some of these AI algorithms, we're able to improve the design of these planes and even help them identify different parts of the heart, whether it be the apex or the valves. Here's just showing you the AI designing these planes. And these 3 different things are actually showing you the true plane, the technologist plane, and then the AI's plane. And you can see they're all fairly close, but they're all a little bit different. So there is, and I believe I can't remember exactly, one of these is, but you can just see there's 3 differences. I believe the blue is the technologist's line, and then the green and the red and the yellow are the AI and the radiology or the true line. So one of the other areas is mapping of the heart, detecting the different layers of the heart, whether it's the epicardium and endocardium. That can be quite challenging. We have different applications, whether it's Circle or Arteris, to help us do this automatically. And it does it well in Cinace for short axis. But one of the areas where they need to develop the technology is in T2 mapping, extracellular volume mapping, T1 mapping, T2 star maps. And so we're developing these algorithms to help you map out that better so you can do this more efficiently and get those values that you need to make your clinical diagnosis. So here's just another big example, just listing a ton of things, whether it's ACL tear detection, neuroforaminal stenosis evaluation, applications to help us increase the speed of MR acquisition, bone strength, decision support technologies, radiology list management systems, stone detections, cardiac motion estimators, ways to help us identify delayed myocardial enhancement. All these things are different ways that AI is being applied in different institutions and companies. So, so all of that is great, and there's all these technologies, but be aware there are things that you should be aware of when you look at this technology. Is that there's some degree of bias in almost all of it. A lot of these AI programs that are developed in institutions have biased data sets, in that the data sets that they use tend to be from their institution. So if they have specific diseases or specific things that they're looking for, the data sets may be more geared towards that, and they may overestimate it versus your patient population. The same is true for the algorithms. The algorithms may be designed based on what their particular patient population has. So it may not always apply to yours. So that's one thing to look at. Again, they're task specific, so you have to find the specific one that you want. You have to find a way to protect the patient's data whenever you're working on submitting these data sets. A lot of the information shows that if you get the patients involved and let them know how their data could be used, they're a lot more open to this and more willing to help versus being surprised that their data was used for something. There's a lot of legal unknowns. Nobody's had any instances yet where we know of legal issues with this. So over the next few years, we may see errors that came because of the use of AI, mischaracterizing things or misidentifying or over-identifying. And we'll start to kind of see where the legal background goes and what the lawyers are going to do about this, as well as just in general, how much we'll trust it or want to go based on this knowledge. So overall, if we want any AI system to be successful, whether it's one you purchase, whether it's one you develop, or whether it's one that you're going to train your residents with, we need it to be multiple things. We need it to be accurate. It must increase our efficiency, the quality of our reporting, the quality of our images, and ultimately add value. We must be more confident in what we're doing because we're using what we're using. It has to help us decrease our burnout. Radiologist burnout is becoming a problem. So anything that makes our job harder is not going to help us. Therefore, it must be simple and it must be a partner for us. That's all I have. Thank you. This is just a list of all the different articles. You can see a lot of these come from the RSNA, and a lot of these are based off the Artificial Intelligence Journal. And like I said, that to me has been one of the greatest resources to see what other people are doing out there. And I encourage you to go just look around on there and open up an article based on anything you see. So if anybody has any questions, I'm going to answer questions for a little bit. Otherwise, that's my email address if anybody wants to email me later with any questions they may have. Thank you.
Thank you, Dr. Hidalgo. It looks like we do have a question in the Q&A box.
Let's see. Is there reimbursement for using these AI tools? The answer to that is no. As of now, there's not a reimbursement the way we would see it with different technologies like contrast ultrasonography, elastography, or one of those other things. The advantage to using the AI tools would be to ultimately decrease the amount of time it helps you to interpret images, therefore allowing you to interpret more images more efficiently. Maybe eventually there will be. We did see eventually CAD developed an AI technology, or there was a reimbursement for CAD. So, as we get further along, as we start to see more standardized technology come out, it wouldn't shock me if we begin to see initial applications for level 3 codes eventually get into level 1 codes for using these AI technology. But that's going to take some time. And as we've seen with 3D printing, there's a lot of steps involving registries and use cases and providing the data. But I think we're a little too early in the implementation to really do that yet. But it will not surprise me if in the future we do start to see that. I think that's all the questions I have. Is there anything else that anybody's wondering?
We'll give it another few more like seconds, see how. Okay, everyone. Well, oh, there you go. There you go. Yeah.
Have I seen any AI apply to OBGYN ultrasounds? I have, and there are a few articles out there that talk about trying to do some of these measurements, the BPD and abdominal circumference and bipyramidal diameters, doing all those different measurements automated. The tricky thing that comes with all of those is segmenting out the particular anatomy probably isn't going to be that hard ultimately once they kind of develop the technology, but there's still the element of tech dependence. We see that with like the easy HRI technology I was talking about. You have to get that right image to be able to get the to get a good picture. You know, if you're off centered or if you're in the wrong place or if you take your image in a different place than the prior person, you can run into issues. So there is some thought that maybe if we can use some kind of three-dimensional cine technology, maybe we can then start to get the best picture to be the most accurate, particularly in thyroid. But I do see AI, they're doing that automation based on the still shots that OBGYN sonographers take for us.
All right. I don't see any other questions that have come through. Okay, thank you, Dr. Hidalgo. And on behalf of the AIUM, our thanks to all of you who participated in this webinar today. I'd like to remind you that a recording of this webinar will be available on the AIUM website under the new Online Learning Center. And please complete the activity evaluation. We hope you'll join us for future webinars. Take care, everyone.
Thank you.